Hi, my name is Deborah Hammond. I'm in the Psychiatric Mental Health Nurse Practitioner Program at Eastern Kentucky University. Today I will be discussing an integrative review I completed of 3 studies which show the efficacy of cognitive behavioral therapy for adults suffering from depression. Depression is a significant healthcare problem affecting over 7% of the U.S. population. Those who suffer from depression are at increased risk for health problems such as stroke and coronary artery disease. Depression is associated with a shortened life expectancy and is the most common associative factor for suicide. 2 depression objectives can be found within Healthy People 2020. These objectives reveal that interventions to fight depression are a national public health priority. Healthy People 2020 seeks to decrease major depressive episodes and increase screening for depression by primary care providers for patients of all ages. To organize a research approach to investigate the efficacy of cognitive behavioral therapy for adults with depression, the following PICO-formatted question was developed by myself. In adults with depression, how does cognitive behavioral therapy compared to treatment as usual affect symptoms of depression over a 6-month period? To find relative articles, CINAHL, PubMed, Cochrane, and PsycInfo library databases were carefully searched. Lee and others conducted a meta-analysis of randomized controlled trials to determine the effect cognitive behavioral therapy has on symptoms of depression. Researchers found 526 RCTs which met criteria for the study after the initial search. Only 6 RCTs met specific inclusion and exclusion criteria. The studies used a variety of scales to measure depression. A 95% confidence interval was used, and p-values of less than 0.05 were considered statistically significant. Study findings by Lee et al. Showed that cognitive behavioral therapy was effective in decreasing symptoms of depression immediately following treatment and 6 months post-treatment. Depression severities of 3 RCTs demonstrated that CBT decreased depression immediately after treatment with a very statistically significant p-value of 0.00001. Depression severities at 6 months post-treatment were analyzed using 4 RCTs. Each study showed a statistically significant decrease of depression symptoms in patients who received CBT. The p-value was 0.00001. Wiles and others conducted a multi-center pragmatic RCT to analyze the effect of CBT on symptoms of depression in patients suffering from treatment-resistant depression. The study included 2 treatment groups, which were randomly assigned by computer code. One group received treatment as usual, the other received intervention. The intervention group received 12 to 18 sessions of CBT in addition to treatment as usual. Treatment as usual consisted of antidepressant medication, support, and advice from a primary care provider. Participants were recruited from primary care practices. There were 469 total participants. 243 were placed in the intervention group, and 235 were placed in the care as usual group. 90% remained in the study for a 6-month follow-up. The RCT included patients aged 18 to 75 years actively compliant with an antidepressant medication regimen for at least 6 weeks, had a Beck's Depression Inventory score of at least 14, and met the International Classification of Disease and Related Health Problems criteria for depression. Depression symptoms were measured prior to the study and at 6-month follow-up using the second Beck's Depression Inventory. Study findings were measured in terms of response. A 50% or more reduction of depression symptoms was considered a response. 95 participants in the intervention group met criteria for response at 6 months, and 46 participants in the treatment as usual group reported response. Using ITT analysis, patients in the intervention group had a 3 times higher chance of response compared to those in the treatment as usual group. The difference in the mean Beck's Depression Inventory score between the control and intervention groups showed a medium effect size. The efficacy of CBT based on the case model found a positive effect on symptoms of depression at 6 months for participants who received all sessions of CBT. Lillyval and others conducted a qualitative study alongside of an RCT which compared a CBT intervention group to a waiting list control group. The intervention group participants completed internet-based cognitive behavioral therapy, or ICBT, modules called MooGym, with weekly face-to-face therapist consultations over 7 weeks. Participants for the qualitative study were recruited from the intervention group after ending ICBT. Recruitment was ongoing until 14 participants were found. Participants were chosen in interviews using propositive sampling to include both genders, both younger and older participants, and participants who did and did not complete the assigned ICBT modules. 2 researchers conducted 60-minute semi-structured interviews to collect information regarding participant experiences in their own words. The interviews were recorded and then transcribed word for word. Participants' experiences of ICBT dictated the direction and analysis of the study. For validity, researchers utilized interview transcripts to analyze the meaning behind patient experience to form themes. 5 themes were developed based on patient interview responses. The first theme, taking steps to address one's problems, spotlights patients' accounts where the simple act of taking steps to receive treatment was a positive experience which gave the patients hope. The second theme involved the usefulness of feedback received from a professional. All interviewees felt that seeing a therapist who helped them with CBT was paramount in their treatment. Affirmations given by the therapist reassured participants and gave them the support they needed to be successful. The third theme revolved around acquiring knowledge. Patients found that learning basic CBT methods was helpful, but had trouble relating to specific situations within the modules which were irrelevant to their situation. The fourth theme involved restructuring the new knowledge attained from CBT. Once the patients adapted the material to suit their needs, patients found that they became more aware of their negative thoughts and began to question the validity of those thoughts. For the fifth theme, patients talked about changes in their perceptions and actions which could be attributed to the ICBT. Patients' accounts accredited ICBT with positive changes in behavior and ways of thinking. Patients were able to break the cycle of negative thinking and inactivity, differentiate between feelings and reality, and become less critical of themselves. Patients described the elements of ICBT to be helpful in reducing the symptoms of depression and improving their overall quality of life. All studies chosen for this review showed that CBT was effective in reducing symptoms of depression in the adult population. Psychiatric mental health nurse practitioners versed in CBT can offer it as an effective intervention or as an alternative to an antidepressant medication for patients who are apprehensive when it comes to taking medications for mental illness. Based on the findings of this integrative review, the application of CBT to psychiatric mental health nurse practitioner practice is the next logical step. All psychiatric mental health nurse practitioners should include CBT in addition to treatment as usual in each session of outpatient therapy for patients who present with symptoms of depression for the expected reduction of these symptoms. Clinics with limited budgets and time constraints should at least refer patients to online CBT sources and smartphone apps. Okay, we have reached the end of the presentation. Thanks for listening. For further information regarding the literature sources, please see the reference list below.